Good morning, guys. I can see a lot of familiar faces actually from Albany Med and way back when I was still a volunteer doctor at WH Camp. Welcome to all. It's a good turnout, and thank you so much for the organizing committee for the invite, especially Scott. I've known Scott for the past 8 years that I've been at Albany Med, fresh from fellowship. My first introduction to emergency preparedness is obviously the H1N1 pandemic. 3 months in the faculty, I'm dealing with the pandemic. The only disclosure I need to have is we're part of the collaborative research and drug trial through do clinical research, and this has nothing to do with my talk today. So if you're an EMT staff or a nurse, maybe you have transferred a patient that have an emergent infectious disease, we would be dealing with those cases today. We would also be looking at, if you're a physician, we would be looking at the clinical course of those emergent infectious diseases, as well as what are some of the evidence-based recommendation in the management of emergent diseases in infectious disease. So if you have a 10-year-old previously healthy male coming to the emergency room with, again, previously healthy, no malignancy, with fever neutropenia, and you have seen this particular x-ray with bilateral pneumonia with fever and ANC of less than 500, there are a couple of things that you need to keep in mind. Certainly, viral and super infection should be in your mind if the patient doesn't have any malignancy or the patient didn't receive any chemotherapy. So this is a 10-year-old previously healthy person with cough, fever of 103. He has some chest pain on the left more than the right, shallow breathing, and poor respiratory effort, and obviously with hypoxemia of less than 90%. And he was incoherent even at the emergency room, prompting intubation. Um, they did several workup after stabilizing the patient, and the white blood cell was less than 1,000. Hemoglobin at 10, platelet just okay at 144, but the absolute neutrophil count is less than 200. Absolute lymphocyte count of 400. We were told several times that after being transferred from an urgent care to Albany Med, the rapid flu test was negative. But common things are common. You will realize later on that the sensitivity and sensitivity of the rapid flu test is really low, in which case a rapid flu test negative test doesn't rule out a flu infection. And that's what we're dealing with this patient. This patient came to our emergency room in February, where you have the peak of the influenza season. So obviously the patient was admitted in the pediatric ICU, pediatric infectious disease got involved. And in review, this is a 10-year-old with fever, neutropenia, and bilateral pneumonia. Whenever you have medical students and residents, or even nurses or nurse practitioner coming with us, you need to give them some pointers on how to take care of fever and neutropenia. The first thing is the guidelines suggest that you need to have a coverage per Pseudomonas, which is the reason why if the patient has fever and neutropenia, regardless if you have received chemotherapy or not, you need to place the patient on anti-pseudomonal coverage, which is the reason why the patient was started on fourth generation cephalosporin. And also, you need to think of your area. Does your hospital has high methicillin-resistant staph aureus for you to say that, hey, we need to also cover for vancomycin, which is a glycopeptide. You can also look at your antibiogram in Albany Med. About half of the 80 isolates per staph aureus are methicillin resistant, which is the reason why we added vancomycin on the patient. We also added clindamycin because in our experience, some of those staph aureus, regardless if it is MRSA or MSSA, they have they're toxin producing. One of them is PBL or Panton Valentin leukocidin. That's why we added clindamycin also, predominantly for inhibition of toxin production. And for the neutropenia, we're not really concerned for malignancy in this patient, but what we're thinking is that, as I've mentioned earlier, more common things are common. We were really thinking that the patient may have a viral infection, and during the season, even if the rapid flu test was negative, we really insisted that I think this would be a presentation of a flu with a secondary bacterial infection. So, and also in most cases, the neutropenia from viral infection persists for 3 to 8 days. So we sent an NP swab or nasopharyngeal swab. In our institution, we have a film array that detects 17 respiratory viruses by PCR methodology. So this patient turned out, and even before the NP swab came about, the result, we started the patient on by mouth Tamiflu or oseltamivir. And having said that, the patient was not flu vaccinated. What it turned out, the patient was positive for influenza B. And the following day, because of the severe sepsis, and that's what I'm telling to you guys, even if the rapid flu test is negative, it doesn't rule out flu infection. So the first thing to do is when you come back to your institution, you have to know what kind of flu test you guys are giving. I know it's summer, I know it's spring, and so was in 2009 when we have the pandemic flu. When we said it cannot be the pandemic, it cannot be a flu. It's summer, it's June, and lo and behold, it's a pandemic flu. Remember, we can read all the books and guidelines we want, but our patient doesn't read the textbook that we read. All right. So if everyone here received the flu vaccine, just to point out to you that you might have received the H1N1 California, H3N2 Texas. And I'm pointing this out, H3N2 Texas. And then you probably have received the B Massachusetts and B Brisbane. Unfortunately, last season, 9 out of 10 of the specimen from the CDC, they were able to know that there's a discordance between what's contained in the vaccine. Remember, I told you in the vaccine it's H3N2 Texas. The one that's circulating in the community is actually H3N2 Switzerland. So there's actually a difference between what's being protected by the vaccine but what's circulating in the community. So what's going on? I think what's going on is that there are some minor changes in the genes encoding for the hemagglutinin and neuraminidase. And that's why we call that a variant H3N2 from Texas becoming a Switzerland. And that's what we call antigenic drift. This is different from what happened in 2009 when we have the antigenic shift, in which, let's say, from H3N2 becomes H1N1, for example. All right, so even if the flu vaccine effectiveness is only as low as 23%, we still, in the last season, we still recommend flu vaccination because you're not actually protecting yourself, but be mindful of those kids that may be immunocompromised and might not be able to receive the vaccine. So I like this one because I was trained in my residency in Syracuse. So if you only have those flu B, inoculating bees to search out people, right? But of course, we also have to respect people who may have religious exemption or philosophical or personal belief. We need to be very encompassing and not be excluding of those beliefs. All right. If your hospital has the rapid flu, there are about 10 FDA-approved screening flu in the market. We love it because the turnaround time is 15 minutes. However, but even if it's that so, it comes with some caveats to it. As I've mentioned, the sensitivity is about 50 to 70%. Also, the accuracy may depend on the prevalence. During the high prevalence season, you may have also high rate of false negative tests. It's just the nature of the test. And this is what I'm telling you guys. Even if the rapid flu test in our patient that I'm telling you was negative, we think the patient has flu because I'm telling this to you, it's an emerging infection. You have to do something now, not later, not tonight, not tomorrow. You have to do something now. That's why we sent the NP swab. We provided for Tamiflu by mouth. And when the patient developed diarrhea, we switched Tamiflu or oseltamivir PO to IV peramivir because there was concern for malabsorption. And I'm just showing you the different respiratory viruses that's being determined using the film array technology. So it's a PCR based, and our patient turned out to be influenza B, as I've mentioned to you. Remember, the rapid flu turnaround time is 15 minutes. The film array PCR is about 2 hours. Some experts consider adding clindamycin to inhibit toxin production. And I think our patient also benefited on receiving IVIG. There's actually less clear evidence on the use of IVIG, but our pediatric ICU team felt that the patient may benefit on it just to neutralize staphylococcal exotoxins. So this is the one that we've used intravenously on the patient because there was concern for malabsorption as part of the sepsis syndrome in the patient. And the indication for use is severe bilateral pneumonia, absolute neutrophil count of less than 500, and there was concern for malabsorption. It's always nice, so that in emergent cases, it's always nice if you have those in your institution. So just a summary, this is an emergent case, which is a dual infection of influenza B and MRSA in a previously healthy child. And also we had given cefepime and vancomycin initially, clindamycin and IVIG as well as initially on PO, oseltamivir, and then intravenous peramivir. The patient was transferred to hospital in Boston for ECMO because he's developing ARDS during the time. The last time I heard is that the patient was already discharged from the Children's Hospital in Boston. Not sure if you can see switching from an adolescent to a baby. Not sure if you could see this picture. You guys had some blueberry muffin this morning. So that is really, yeah, that is how really it looked like. If you could see those blueberry, it's actually, that's how you call it, it's a blueberry muffin rash. There are different differentials that you can come about, like congenital rubella, which is the most common during the pre-vaccine era. But the mother of this baby is rubella immune, meaning she's vaccinated when she's younger. Another one would be meningococcemia, probably least likely, but a possibility, you know. And this is what we're thinking for the patient, congenital CMV. And I'm sharing this to you guys. This is a baby that was transferred somewhere in Bassett Healthcare to Albany Med. The baby is in front of you. You did your history. You saw this baby. You're seeing this baby. It's an emergent case. You have to do something now, not later, not tonight, not tomorrow. So what we did in the baby is that clinically, this is really because among all of those, other than meningococcemia, you can do something about congenital CMV. You can give actually initially intravenous ganciclovir and then eventually PO by mouth, valganciclovir. If there's a clinician in the room, this actually, or a pediatrician, this is actually a board question. They would be asking the pediatrician in the boards, what are those blueberry muffin-like lesions? And those are actually, in the setting of profound anemia, the baby is trying to produce more red blood cell or white blood cell outside the bone marrow. And that's the board question is about. So it's an extramedullary dermal erythropoiesis. And the pathophysiology is not clear actually. They said that there may be some hematopoietic stem cells that migrate from the bone marrow to the skin, or there are some dermal mesenchymal cells in the skin itself that differentiate inside into blood-producing cells. Remember, the body is trying to compensate for profound anemia. So, and that's the reason why this is an emerging disease. You really have to think about right now, if the baby is in front of you, what do I need to do right now to make sure the baby is taken care of? And don't feel isolated. There's always a phone call to do. You know, I can call. It doesn't have to be me always, by the way, from Albany Med. There's four of us, so you can always call us. Sometimes people would say, well, it's kind of expensive to bring patient to Albany Med. But if you have an infectious disease online, the price for the patient is, I think it's priceless. We'll be able to guide you on what to do on your patient. Even if the patient is in our hospital or in your emergency room, we'll be happy to help you. The white blood cell is 13,000, hemoglobin of 14. Normally, if you remember, babies would have hemoglobin of about 17 to 18. And platelet, obviously thrombocytopenia because of disseminated congenital CMV. We know it's not rubella because the mother is rubella immune and the baby is term, which means that the baby has a correlates of protection from rubella from the mother if the baby is born greater than 34 weeks. 34 weeks is like the magic number in which the antibody from the mother gets transferred to the baby via the placenta. And the mother is syphilis negative and HIV negative. Obviously admitted in the nursery ICU, one-day-old blueberry muffin syndrome, congenital CMV is our initial working diagnosis. We sent the patient's CMV PCR in the blood, in the urine. We didn't wait for the result to come back, by the way. We started the patient on IV ganciclovir. And of course, came back the following day that turned out to be CMV PCR positive from the urine, are we surprised about that? And you should not, because that's what you expected, right? We should be doctors, or we should be medical providers. That's what your clinical suspicion. You send the laboratory test to confirm your clinical suspicion. So when it confirm your clinical suspicion the following day, you're not surprised. That's what you expected. All right. Next. So I don't want you to be memorizing the doses. I don't memorize them as well, because they're like moving targets. You always have to consult your formulary if you have one. Um, the treatment recommendation for these two are the recommended treatment for congenital CMV with or without CNS involvement. Our patient turned out to have seizure, and also the patient also had bilateral sensory neural hearing loss. But the good thing about the treatment nowadays, we used to treat congenital CMV with 6 weeks of treatment. Now there's a new guideline that came out this March that turned out that we can treat patient up to 6 months, and I'm going to tell you why. And you have to start this antiviral treatment within the first month of life. It has a lot of benefit as far as improvement of the hearing loss, and also prevention of neurodevelopmental delay in the babies. So 68% if you give ganciclovir would develop neutropenia, much less if you give valganciclovir. Some patients, if they develop neutropenia, they benefit on GCSF or stopping initially or midway the antiviral regimen. This is the study that was published by Kimberlin et al. In the New England Journal. So they do a randomized clinical trial trying to compare eventually valganciclovir 6 months versus 6 weeks, meaning short-term versus long-term treatment. The primary endpoint is what will happen if you give 6 weeks versus 6 months at the 6-month hearing test of the baby. Would there be improvement of the hearing problems or not? And also they look at the long-term outcome. What happened with whether, let's say, if the hearing loss continue to have a hearing loss at 12 months, at 24 months, or if there's a hearing loss, if you give 6 weeks versus 6 months, did it improve at 1 year or at 2 years? So they enrolled about 100 babies. If you give 6 weeks or 6 months of valganciclovir, there's no difference at 6 months outcome. However, they start noticing that if you give the 6 months, it's actually better for the baby. The hearing outcome at 12 months is actually better in the 6-month valganciclovir group. And also, even at 2 years old, there's also significant improvement, but not also on the hearing evaluation or hearing test. There's also neurodevelopmental benefit as far as the language composite and receptive communication scale of the baby if you give 6-month valganciclovir versus the 6 weeks. The grade 3 to 4 neutropenia, meaning severe to profound neutropenia, is about the same. There's no significant difference if you give 6 weeks and 6 months. So that's a good deal, right? You have improvement with 6 months, and you have less side effects, or the same side effects as the 6 weeks. So the current guideline right now, which is fresh from New England Journal, is that 6-month valganciclovir is now the treatment duration for PO valganciclovir for babies with congenital CMV. All right, this is just a summary of the baby, and that's what we did. There's some malabsorption problem with the baby concerning for necrotizing enterocolitis. That's why we gave initially IV ganciclovir, and then switched to PO valganciclovir. The patient developed neutropenia, but we didn't actually discontinue the valganciclovir. Instead of giving twice daily, we gave it once daily. And then neutropenia improves. That's why we were able to bring it up to twice daily again. Obviously, the baby needs a close follow-up for audiology. I saw the baby a month ago, and the bilateral hearing loss, at least one ear, can hear already by ABR testing. So that's a good outcome. And the baby is not yet done with the 6 month. He's finishing the 6 month for 1 more month of the valganciclovir. All right, moving along. So this is a young child who presented to the emergency room with severe abdominal pain, nausea, vomiting, and diarrhea with fever. So the emergency room staff at Albany Med were able to do an ultrasound that's showing thickening of the gallbladder and some fluid around the gallbladder. They were able to do also the CT scan of the abdomen showing multiloculated cysts concerning for an abscess in the right hepatic lobe. There was concern that there may be some extension of the abscess not only in the liver but also in the abdominal anterior abdominal wall, and that's what this multiloculated cyst is also showing, not only in the liver but also in the anterior abdominal wall. And also, the patient presented with increased workup breathing, and there was suspicion that this may be the same problem from the gallbladder, the liver, anterior abdominal wall to the lung parenchyma. So this is a 7-year-old previously healthy female with nausea, diarrhea, severe abdominal pain, fever, hypotension. Long story short, there's concern for sepsis, and the patient was eventually admitted for sepsis evaluation. I'm placing this one probably infectious disease specialists are one of the one that really ask a lot of questions, and I'm placing that particular epidemiologic history for a reason, because the infectious problem of this child came. It's very refreshing for us because there were some report in South Asia presenting also this way. But the interesting problem with this patient is that they have not left upstate New York ever. We even go forward in thinking about, well, are there any family members or friends who may travel in South Asia that may also have this disease problem? And the answer is none. So moving along, I've showed you the ultrasound of the abdomen showing multiloculated mass in the right hepatic lobe. They were We were able to do a CT-guided drainage. Initially, we were thinking that probably it's an amoeba or amoebiasis as the one causing this abscess. But during the drainage, we were not able. We only see 200 ml of purulence. It's not the chocolate-like consistency or an anchovy paste-like consistency that's reminiscent of amoebiasis. So we begin thinking and say, well, okay, why don't we send that for aerobic and anaerobic culture? And what we find out is actually the one that's currently being reported during that time, that there is some outbreak of Klebsiella pneumoniae causing liver abscess and also lung abscess in South Asia. Remember, the patient has not traveled in that area. So it's growing Klebsiella pneumoniae that's positive for hypermucoviscosity phenotype. When you get the chance, it's actually cool to go down to microbiology lab, and actually this is actual colony and culture of the patient's Klebsiella pneumoniae isolate. So it's positive for hypermucoviscosity. That's if you have a Q-tip and touch the colony, you would see this mucus strand coming from the colony, and it's positive if it's greater than 5 millimeter. Why do we want to know that? If you have that kind of phenotype, it's actually going to give the clinician an idea that the patient's isolate has a virulence factor, that you should look for other site of abscess, not only in the liver, look for other site, maybe in the lungs, maybe in the anterior abdominal wall. Her hospital course was complicated by bacteremia due to Klebsiella. They have to remove the gallbladder. I've shown you that she developed some pneumonia with diffusion, and they have to place a chest tube. She improved while on antimicrobial regimen for 2 to 3 weeks. And this is one of we are in an academic institution, so we collaborated with the people from California Department of Health, and we were able to show that the virulence factor with that phenotype, meaning the characteristic of the isolate has the hypermucoviscosity, we were able to correlate that with the genotype of the patient. And they harbor those two bands. Those bands are the ones responsible, those are the genetic codes responsible for the hypermucoviscosity. And so, and the reason why we are interested in that is that the hypermucoviscosity would tell the clinician to look for other foci of infection. That's why it's an emergent disease. And this is the first reported case. My colleague, Dr. Li Pao, and one of our MedPed resident who's now doing her infectious disease fellowship combined program in Cleveland is actually the one who presented this in the American Academy of Pediatrics. All right. If you guys have any question, feel free to stop, by the way. Just sideway. So this is an adolescent. We're also HIV specialists. If you have an adolescent perinatally infected with HIV, with difficulty of breathing, and with this chest X-ray, what would be the first thing that you need to think about? I heard pneumonia, pneumocystis pneumonia, right? This is a very interesting case actually. That's actually what we're thinking also. So as I mentioned to you, 17-year-old perinatally infected with HIV, admitted for respiratory distress, and similar to other adolescent, even if we try to give antiretroviral treatment, uh, this is an adolescent patient, they don't want to take the medication. And that's why they have AIDS. And unfortunately, with fever, cough, increased work of breathing, he was eventually admitted in our intensive care unit. But what's surprising is the oxygen saturation in your room air is 96%. Conventional knowledge suggests that if you have PCP or pneumocystis pneumonia, suggests that you need to have hypoxemia, which is it's part of the textbook. Remember, I've told you we can read all the textbook we want, but sometimes our patient doesn't read them. Unfortunately, the patient's Bactrim, which is the drug of choice, or the trimethoprim sulfamethoxazole, was discontinued because the patient doesn't have hypoxemia. Probably it's something else. Guys, more common things are common before we think of something else. Um, so the patient also had bacterial pneumonia. He was started on a quinolone for coverage of atypical pneumonia. And also his course was complicated with candida esophagitis and diarrhea. That's why he was given initially intravenous fluconazole. So this one here, we were, if you're with us, working with us in pediatric infectious disease, whether you call us to your emergency room or your hospital, we are a very persistent group. Even if you tell us that a 17-year-old with AIDS, with CD4 of 6, the magic number, by the way, is anything less than 200 is bad. And if you're telling me that this patient has AIDS and not taking the medication, but the oxygen saturation is greater than 95%, this probably is not PCP, I would really insist and tell you that, we need to make sure it's not. I would continue the Bactrim. I would get some respiratory secretion. And this one is the respiratory secretion, what you will find in the textbook. So you could see those cyst-like structures. And this is actually the respiratory secretion from our patient. We work, we had good collaborations with our microbiology as well as with our pathology group. So we asked them to call us what they find out. And in their own words, they said that the respiratory secretion from our patient is studied with PCP. So that's the Gomori methenamine silver stain of our patient showing pneumocystis, even if the patient didn't present with hypoxemia. All right. The usual presentation of pneumocystis pneumonia, it's actually, we used to call it pneumocystis carinii pneumonia. They just changed it to pneumocystis urovetsi, but it's still PCP because it's still pneumocystis pneumonia. Sometimes they would present with subacute diffuse pneumonitis, dyspnea, tachypnea, and oxygen desaturation. Remember, our patient doesn't have oxygen desaturation. The reason why it's an emergent, if that patient is in your emergency room, if you don't treat the patient, the mortality is 100%. If you treat the patient, the mortality is about 5 to 40%. That's why it's an emergent disease in infectious diseases. The patient is in front of you. You have to start trimethoprim sulfamethoxazole now, not later, not tomorrow. Sometimes the chest X-ray can have bilateral diffuse interstitial. In our patient, it actually showed more of a lobar presentation. The definitive diagnosis would be sending respiratory secretion to pathology for the GMS or Gomori methenamine silver staining, and that's what we did. That's why we were able to come up with the diagnosis. But even then, it confirmed our clinical suspicion that probably this is PCP. That's why we started trimethoprim sulfamethoxazole, send the respiratory secretion, and wait for the result. We treated the patient initially with intravenous trimethoprim sulfamethoxazole for at least 3 weeks, followed by mouth. We also have started the patient in secondary prophylaxis with single-strength trimethoprim sulfamethoxazole. In summary, 17-year-old with AIDS treated for PCP was eventually placed for secondary prophylaxis for pneumocystis. He was also treated with fluconazole for candida esophagitis, was also placed on suppressive regimen, once daily fluconazole. and also MAC prophylaxis. Any patient with AIDS with CD4 less than 50, you also have to give them azithromycin. Adult dose is 1200 milligram once weekly for the Mycobacterium avium complex prophylaxis. And more importantly, you need to start combination antiretroviral therapy. Unfortunately, the patient didn't start. I think he started on and off on combination antiretroviral. So I think you guys probably recognize this, the backbone of an NRTI, Truvada, and a primary drug, which is an NNRTI or rilpivirine. This one pill combination is Complera. And this one, we have to give an additional integrase inhibitor because of the complex mutation archive of our patient's HIV. Our patient actually, unfortunately, is in hospice care right now. All right. So let's say if you have a 4-month-old baby presenting in the emergency room with eczema exacerbation. I'm not sure if you could see all those studded lesions on the baby. Those are vesicular lesions and coming to your emergency room. The patient is toxic looking and with fever. One of the things you need to think about would be, anyone? I heard it. I think I heard it. Eczema herpeticum. So if you have an eczema or atopic dermatitis and you're exposed to herpes simplex virus type 1 or type 2, let's say if there's family members who has oral ulcers due to recurrent oral sores and it get transferred to the baby, you have an open skin, it can go around the baby's skin, the entire body, and you would have eczema herpeticum, which is obviously an emergent disease because you have to start acyclovir as soon as possible. All right, we were following 3 patients during that period between May and August 2011. The mother of that baby presented with an oral ulcer, but the 2 patients did not. They have a history of fever, and all are very sick looking in the emergency room. That's why they require admission and starting of IV, acyclovir, and some of them may have secondary bacterial infection. They have varying age group with eczema from 4-month-old to 10-month-old to 7-year-old. All of them has worsening of disease with secondary bacterial infection, presenting with MSSA or methicillin susceptible Staph aureus bacteremia or even skin and soft tissue infection. They require antimicrobial regimen on top of the antiviral regimen. On this patient, once you treated them for 10 to 14 days, you have to give them suppressive regimen to prevent recurrence in the future. It's a dermatologic emergency because we really need to start intravenous acyclovir in the patient. It's not very common among immune-competent patients, but are more common immunocompromised and also among patients with primary dermatologic conditions, such as those with eczema, because their skin obviously is open and the organism can just get inside easily. The reason why it's emergent is because you have to recognize it the first time it presents to you. Because if you fail to recognize it, it would have some serious consequences, obviously, in the patient and would require prolonged hospitalization. In our patient, we were able to recognize most of them within less than 48 hours. All right, we are in the summer, spring season. This is something that we all see in our area, hand, foot, mouth disease. The most common cause is Coxsackie virus A16. There are some ulcers in the hand, some ulcers in the foot, and obviously some ulcers in the mouth. So it's a clinical diagnosis. It's very benign. However, in November 2011 to February 2012, there is a severe presentation of hand-foot-mouth disease. They're actually first described in Alabama, California, and Connecticut, and also Nevada. And they present like this. So this is due to enterovirus or Coxsackie virus. But isn't this very similar to the babies I just shown you with eczema herpeticum due to herpes simplex? And that's the reason that even if this is benign, I'm showing it to you because so that you can differentiate them. And I'll give you some of the pointers on how to differentiate, let's say, and all of this, and this patient that we have seen in our institution also have eczema. They have also atopic dermatitis, and they present with blisters all over, similar to the one with eczema herpeticum, but they're not toxic looking. If you have a 3-year-old with eczema with severe hand, foot, mouth disease, they're like planets circling around you in the emergency room running around, compared to a patient with eczema herpeticum in which they're really sick looking. So that's the major difference. They're not sick looking, and they used to have fever, but not in the emergency room. So we were following some of those patients with severe hand, foot, mouth disease. There's about 4 of them, and this is the single most important signs and symptoms. All of them have no more fever by the time they're presented to the emergency room, and they're not really toxic looking. So this is the hand and the arm of 4-month-old with severe hand, foot, mouth disease. This is the 1.5-year-old lower extremity picture. You could see the crusting, and that used to be blister-like lesions at the back of the knee of a 1.5-year-old patient. Again, a hand, foot, mouth disease in a 9-year-old. You can see similar lesion. So if you have an eczema and you're infected with herpes simplex, you call it eczema herpeticum. If you have eczema with skin opening and you're infected with severe hand, foot, mouth disease, we call it Kaposi varicella eruption. No need to memorize, I'm just letting you know, so that when you read something in the literature or in the medical journal, oh yeah, I heard about this. This is just an eczema herpeticum. It's called Kaposi varicella eruption, but it's due to severe hand, foot, mouth disease. We collaborated with the New York State Department of Health. We were able to know, remember I told you the most common cause of hand, foot, mouth disease is Coxsackie virus A16. The severe form is being caused by Coxsackie virus A6. This is just the phylogenetic analysis of those 4 patients that we have. They're really closely related to each other to be Coxsackie virus A6. All right. So this is one of the rare presentation of hand, foot, mouth disease. It's a generalized eczema exacerbation with blisters all over, but they're not really toxic looking. It only requires supportive care. And the reason why this is an emergent case is because you may confuse it with herpes simplex. It's not totally wrong to start the patient on, let's say, hey, I cannot rule out that this is herpes. What I can do is I can send swab specimen for HSV and enterovirus PCR. I'll send that, and then I'll start the patient on acyclovir. That's totally fine. Once you have the result, oh, it's enterovirus, it's Coxsackie virus. Now I can stop the now I can stop the acyclovir. It's also good to do like that. All right. We discussed a couple of cases that may be emergent infectious diseases such as co-infection with MRSA and influenza B. We also discussed about blueberry muffin syndrome, primary liver abscess due to Klebsiella pneumoniae in a baby who doesn't travel in Asia, and also pneumocystis pneumonia, as well as eczema herpeticum and Kaposi varicella eruption or severe presentation of hand, foot, mouth disease. We also look at their clinical course as well as look at the medical evidence on how to treat them. And if you have any question, and it doesn't have to be Albany Med, by the way, I can assure you there are also great infectious disease specialists in other hospitals, but we'll be happy to help you. And with that, thank you so much. We probably have some time for questions. Go ahead. You know, for some a good thing about EMS staff would be, when you're transferring this patient, I always tell the nurses and the EMT staff that I know of, always have not only standard precaution, but also if you have gowns to use them. But more important is at least gloves in transferring this patient if you're transferring them from one hospital to another. Because I always tell them to make sure to wash your hands always so that you will not bring this type of diseases at home. Other than that, unless the patient is really critically unstable, you really have to stabilize them. in transport. Yes. I actually like the question. She's a good friend, by the way. It's way back from when I was a volunteer doctor in Double H camp. I think you should volunteer. It's really great experience. Um, I was in Nathan Litauer Hospital last week, and they have the same question. We struggled, and you can talk to Scott Heller about that kind of question 5 years ago. In Albany Med, as an institution, we we sat down, thought about it, and 5 years ago we decided that we're going to not use the rapid test. We wanted to use, we initially use a home brew or homegrown PCR for influenza because we know that a negative rapid flu test, especially during the high prevalence season, may have high negative, false negative tests. So it really boils down to what your institution, what is available in your institution. You really have to know. It is something that you could discuss with your institution. There's always room for discussion. And that's what we did 5 years ago. It only takes a person to ask the question. And in Albany Med, we just figure out that, hey, this is not going to be the best interest of our patients and our providers. Let's start with the single PCR. Then now we're up to 17 respiratory virus PCR determination in a single test with a turnaround time of 2 hours. I'm not promoting the company, by the way, even if one of my NICU fellows is doing research on that also. What I'm saying is it boils down to what is available resources in your institution. Yes. Similar Klebsiella Pneumoniae.
That presented. Sorry, thank you. Were there similar cases of the Klebsiella pneumoniae that actually were presented in the region?
In our area here, that's your question. I don't know actually. We also do a monthly infectious disease conference with our adult providers, and so far they have not presented one. We were just attuned to that particular strain. As specialists or as clinician, we need to go to different conferences also. And when we came back from a conference, we said, well, initially we were thinking it's amoebiasis, and then it turned out to be Klebsiella. Well, and then we said, hold on, there's a lot of cases in the South Asia that was just reported in the recent conference that we attended. Why don't we go down to microbiology and do additional studies? There's really no additional one that I could have remembered being reported in that area. And even we also have the emerging infectious network through the CDC as well as the epidemiology surveillance email that we would receive. I've not seen so far anyone who has that.